Okay, we're back with, believe it or not, part two of basic airway management and ventilation. Basic airway management and ventilation includes most airway maneuvers that have been shown to be life saving, including proper positioning, suctioning, oxygen administration, bag valve mask or BVM ventilations. Uh, Paramedics must continue to focus on these basic skills. Again, I'll say it before, I've said it again, I'll continue to say it. If your BLS fails, ALS will fail every time. You have to take care of the basics. Basics will get you through everything. Despite their advanced training and techniques, it is easy to get tunnel vision when considering endotracheal intubation or other advanced procedures. Yet these techniques are rarely life-saving and are often worthless if not preceded by good basic management. It's like setting your foundation. If you build a poor foundation, it doesn't matter. A poor foundation on the Taj Mahal is still going to crumble into a pile. Same with your skills. If your basics are not solid as a solid foundation and you don't continue to maintain them, then your ALS skills will crumble because you can't take care of the basic. Your ALS is going to be useless. As the senior member of of most EMS teams, it is the responsibility of the paramedic to ensure that other providers on the scene are performing optimal basic airway management. Lead by example. Lead by example. If your skills are solid, practice regularly and teach people below you. As a paramedic, it is your duty to pass those skills on and pass those basic skills on and pass down the respect and the determination. Determination is not the right thing. The pride in your skills to the next and show them that is the way to go. Build those basic skills, bolster those basic skills, and your ALS will be more successful. So let's move on to proper positioning. Trauma patients are often confined to the supine position as a result of spinal immobilization. So we've got them strapped to a board if you're still doing that, or if you're doing spinal motion restrictions. They may not be on a board, but they are stuck at the most, I believe it is a 30-degree incline. We'll discuss that more later. But they are still stuck supine. And they are still in a C-collar. However, some circumstances warrant flexibility if permitted by local protocol. Always default back to your protocols. They are what you are going to be held, the standard you're going to be held to. For example, if a patient with facial and airway trauma is able to maintain his airway as long as he is sitting up, he may be placed in a cervical collar in a seated position rather than a restricted to supine position. Again, that depends all on your protocol. If a position of comfort is allowed or a position of function is allowed, then by all means, let's use that. A conscious medical patient should be maintained in their position of comfort if they are not placed in a cervical collar for immobilization. Unconscious medical patients who do not require other interventions, such as BVM ventilations, should be placed on their side with the head elevated, if not contraindicated, to maximize, not to maximize, but to minimize the risk of aspiration. So basically the recovery position with the head of the cot up just a little bit. Generally, we are not very good in EMS at transporting an unconscious patient in this manner. We usually have them supine with the head up to a semi-Fowler's position between 30 and 45 degrees, which isn't bad either, but they can still vomit. And if they lose control of their airway and we don't know this and we're not watching, if they vomit, they can easily aspirate in that position. The unconscious patients who do require airway and ventilation intervention, such as BVM or intubation, are usually best maintained in an ear to sternal notch position, in which the supine patient's head is elevated to the point where the ear and the sternal notch are horizontally aligned. So this is going to be accomplished by blankets or padding under the head, uh, not necessarily the neck, but unless support is needed. But you're going to raise the the head, and the neck will angle a little bit and make that ear, the auditory canal, level with the sternal notch. And there should be a horizontal line at that between those two landmarks. The position is often referred to as the sniffing position in non-obese patients. The ramped in non-obese patients, and the ramped position with obese patients. So your normal body structure patients to a little bit larger patients will use this sniffing position. If you think about it while you're sitting up, it's kind of your head out, your head up just a little bit, like you walked into grandma's house and you smell cookies or pies or whatever your grandma is known for making. You take that first initial sniff. That's the kind of position you want, but in a supine position. Your obese patients, you're going to be in a ramped position, and that's exactly what it sounds like. You're going to ramp up the padding to lift the upper body and tilt that neck just a little bit, and all of this is going to come up. And what that ramping position is going to do also is take pressure off the diaphragm. It's going to kind of raise that upper body just a little bit to get the internal organs and all that adipose tissue to push down rather than up onto the patient's diaphragm, and allow for less interthoracic pressure from the abdominal area. This position maximizes upper airway patency, allowing for effective ventilation if required, endotracheal intubation. It improves the mechanics of ventilation with both spontaneous breathing and with the BVM ventilation. Again, by opening that up, especially the obese patients with the ramp, is letting those internal organs push down. Kind of got ahead of myself, and here's that diagram that I was speaking of. Here's that horizontal line, and you notice the padding behind the head here, lifting up, and from the ear to the sternal notch is a horizontal line. That's that sniffing position, head out. If you tilt this on edge, if you got a tablet or a computer, laptop, something that you can tilt, you'll notice that if they're standing up, their neck is slightly extended forward, and their head is back just slightly to kind of open up and maximize the airflow coming in. Do I have? Okay. So now we're going to go to oxygenation. Oxygen is an important drug. You must thoroughly understand its indications and precautions. Providing supplemental oxygen to patients who are frankly hypoxemic will diminish the hypoxia's secondary effects on organs such as the brain and the heart, and lessen subjective respiratory distress. In some circumstances, oxygen administration also indicated to keep the patient's oxygen saturations may be normal. Keep in mind that the oxygen may be carried both in hemoglobin and dissolved in the blood. Under normal circumstances, the dissolved portion of the oxygen is relatively insignificant. When supplemental oxygen is administered, the dissolved portion of oxygen may increase many-fold. This relatively small amount of extra oxygen may be important to patients with tissue hypoxemia for any cause such as septic shock, myocardial infarction, cardiogenic shock, or severe trauma. Oxygen administration is also very important prior to intubation, regardless of the oxygen saturation. So if they're satting well, if your bag valve respirations are doing, or ventilations are doing well and doing what they're supposed to, you've got good compliance, you've got good chest rise, equal chest rise, good clear lung sounds, and you're getting great oxygenation, and you're satting up 95, 96, 97%, 98%. and you're getting that good oxygenation and everything, but you still feel that you need the intubation, um, adding the supplemental oxygen and pre-oxygenating before you attempt your intubation is it's incredibly important. Um, the patient can desaturate pretty quickly in the pre-hospital setting. One of the things that you guys get to do later on is when you do your clinical and you go into the OR, you get to see just how long a pre-oxygenated patient will hold oxygenation without respiration. Some of the CRNAs are very good about demonstrating this, and you can see people that have other problems that they may not hold saturation just as long. It's pretty interesting. It's a very unique opportunity that you guys will get to experience. But the long and short of this is never withhold oxygen from any patient for whom it is indicated. Uh, so if you feel they need oxygen, they demonstrate the need for oxygen based on your assessment and your clinical findings, then give them oxygen. Caution is advised in patients with COPD who may have developed the hypoxic drive to breathe. As we discussed prior, this is where they reduced oxygen levels are what triggers the respiration instead of the CO2 levels, as opposed to normal hypercarbic drive. These patients, there is a theoretical risk of depressing respirations at the body senses plentiful oxygen, that they will shut down and they will no longer that they'll go apneic. It rarely happens unless it's like a very long transport and it's super high concentrations of oxygen are given. In the 20 to 30 minutes that we have a patient for a normal pre-hospital call from home to ER or from location to ER, I don't believe I have ever read about, and I may be mistaken, but I don't believe I've ever read about losing knocking out a patient's hypoxic drive. If I remember correctly, I believe it takes up to 24 hours at high flow oxygen to knock out that hypoxic drive. So if the patient needs oxygen, give them oxygen. As we said before, though, in our O2 saturations, our goals, let's go ahead and keep that down around 90% rather than over 94% like we would a normal healthy individual. You don't necessarily need to return the patient to a normal oxygen level, as their bodies are generally used to lower oxygen levels, but you should monitor your patient for evidence of respiratory depression. You also could use capnography to assess for early signs of worsening hypercarbia. As discussed earlier, there's evidence that high oxygen levels, hyperoxia, can be dangerous as low levels as hypoxia because of possible formation of the free radicals. This has been demonstrated in post-cardiac arrest patients, stroke patients, neonates, and head trauma patients. Therefore, oxygen saturation should always be maintained in the normal range using the lowest necessary oxygen flow. And that's why we revert back to the escalating airway algorithm. We want to do the least amount that gives the most benefit without causing further harm. So just dumping oxygen on 15 liters of non-rebreather on a patient that is satting 93% is a little overboard. We don't want to drive that up to 100%. We just want to bring it up to 95, 96%. I think we'd be fine with that.